acute infection rates are not decreasing everywhere. I think it was said here that ecstasy is very in vogue, opiates less so, methamphetamines may be on the rise in Amsterdam, but the truth is that I think that people's preference in the drugs they use is not fixed over time, and we are seeing in the United States, and John Ward showed this slide as well, a heavy increase in opiate use with subsequent dramatic rises in hepatitis C virus infection rates. So the red states on this map are maps in which we've seen increased rates of hepatitis C between 2010 and 2014, and I would argue that the white states, which are states for which we have no data, are largely in the red category as well. So we are in the middle of a huge opiate epidemic with rising hep C rates in the United States, and we may not be alone. So do we need a vaccine? I think the therapies are dramatically better, as we all know, and for which I'm very grateful as a person who actually takes care of patients with hepatitis C virus infection. But there are some patients who experience side effects. It's a very small percent, and as we know, there are now controversies about whether there's increased hepatitis B flare with treatment of hep C, progression of hepatocellular carcinoma, but even without those, which we haven't got solid data on at this point, we know that some patients experience some side effects. It is, as everyone knows in this room, very challenging to find the people who need treatment. And that's because, as everyone realizes, that while it may have side effects for patients, it is largely not such that people present for medical care as a result of their hepatitis C until they have end-stage liver disease. And additionally, knowledge of infection status has been extensively covered in this conference and is limited worldwide, although many here are working to change that. So we all know the high-risk groups for infection tend to be marginalized, including people who inject drugs. And I'm going to show a slide that's already been shown twice, which is this excellent modeling work from Peter Rickman, showing that antiviral therapy might be used to reduce prevalence of hep C in people injecting drugs. But if you look at really what my population of people injecting drugs is like, with a high prevalence of 60%, and you achieve an SVR of 62.5%, which I think is quite achievable. But if you basically treat these individuals on even high rates, you'll see essentially a 7% decrease in prevalence over 10 years. And I think many of us would argue that that's not really going to get the job done. So as well, people who are more at risk for hepatitis C live in highly endemic regions of the world. I think these data are essentially known to everyone, that many, many people in the world who have hepatitis C live in countries in which there are somewhat limited resources, and they will not be able to treat everyone, and they certainly will have difficulty testing, treating, and doing some of the other things that I think may be important in the future, including assessing people for resistance-associated variants, which I'll talk about a little bit more. In addition, the medications we have do not alter the immunologic state of the patient for the most part in a way that provides protective immunity. So what we see is that people who are treated for infection can be reinfected. That was really nicely talked about by Olaf Dahlgaard yesterday, and people who inject drugs. And also that has been shown by others, as well as men having sex with men. Hickman and others have shown that this is a problem in people who are at ongoing risk of hepatitis C virus infection, including people who live in endemic regions of the world as well. I think this was also well discussed this morning by Dr. Nelson regarding the potential for DAA resistance, but as was discussed, persistence of these resistance-associated variants seems to be likely in NS5A, and at least for pre-acquired, prior to treatment, NS3 resistance-associated variants as well. If we basically start rolling therapy out to populations of patients less likely to be compliant with therapy, it is at least possible that we will see increased resistance-associated variants. And if they do have an implication, we decide that we need to assess resistance-associated variants in the population, I think that's something that's unlikely to happen in treatment resource-limited settings. So if I combine those last two things, drugs not providing protection against reinfection and the potential for DAA resistance unknown, what we actually think about is transmission of resistance-associated variants, and that has actually occurred. It began as soon as we started clinical trials of these agents. So going back to telaprevir clinical trials, so as soon as we started using them, we saw transmission of resistance-associated variants. We had an HIV-infected patient who had hepatitis C. They were partners. There was an SVR achieved upon treatment of one. The other actually failed treatment and had a known tolacrovir resistance associated variant. And unfortunately, the effectively treated partner was infected with the resistance associated variant by his partner who failed therapy. So again, this was early clinical trials with the early agents, and this has continued to occur. So the last point I'm going to make about why I think treatment is not the only way to solve this problem is that in the later stages, it does not reverse all the disease that we see. So this shows liver failure percent on the, let me see if I can get the pointer. Liver failure percentage on this axis over time, and you can see that treatment is incredibly important because with sustained virologic response, the rates of liver failure are much lower than in those who are not effectively treated. However, what you see is even in people who have effective treatment of their Hep C, there is some progression to liver failure, and we actually see the same thing with hepatocellular carcinoma. So this is the cumulative incidence of hepatocellular carcinoma. The difference here is that everyone in this graph is effectively treated. So this is, all these patients achieved sustained virologic response, and what we're seeing is cirrhosis or not cirrhosis. In people with cirrhosis, you can see there's still substantial development of hepatocellular carcinoma over time. So there's a saying, an ounce of prevention is worth a pound of cure, and I think that remains true. We cannot undo all the damage of hepatitis C by treating it, and as all of us know, there are patients we don't identify until the late stages of disease. So I think that for those reasons and others, I think development of a vaccine is critical in the campaign for eradication, and so that raises the question, is it possible? So one of the things that made people a little bit discouraged is that people who successfully spontaneously control hepatitis C can be reinfected as well, and they can in some cases develop persistent infection. But I think the data suggests that that's an unusual outcome, and there is some evidence to suggest that we can generate protective immunity against hepatitis C, which I'll go through very briefly. So I direct a cohort of people who inject drugs called the Baltimore Before and After Acute Study of Hepatitis, or BBASH. And basically, we take young people who are Hep C uninfected both by antibody and RNA testing, and we provide basically needle exchange, needle and syringe programs in Baltimore City provide needles, syringes, cookers, cotton, rinse water, everything but the drugs. We refer them to that, to drug treatment programs, and unfortunately, and we have peer counselors as well as experts, and unfortunately some of them become infected despite our best efforts. And so what we see basically is that the vast majority of them are persistently infected, which is, persistent viremia virus is the red, antibodies are black bar on the top, some spontaneously clear. To put some numbers on that, basically we looked at 113 people who acquired HCV in our study, and about 27%, which is typical with most cohorts, control. About half of them became detectably reinfected, meaning we've measured a different virus than they had the first time in their blood. And of those, instead of a quarter of them clearing, 83% of them cleared the infection. So the rates are completely reversed. So people who are infected multiple times are much more likely to control infection. This has been shown by multiple people in this room, and that could just be some pre-existing fixed genetic trait, but it's not, because they don't just clear the infection, they do it better and better. So if we look at primary infection, maximum HCV RNA levels and subsequent infections, you can see a significantly different maximum HCV RNA, despite the fact that we're sampling people randomly after the time, not randomly, but on a monthly basis, but the time we sample them relative to when they become infected is random. And despite that, we see that in subsequent infections, they have much less HCV RNA. That's been confirmed in multiple groups. And so they have less virus when they become infected, and they also have a shorter duration of viremia shown here, with the initial infection shown and subsequent infections, duration of viremia. So they have lower levels of Hep C RNA and shorter durations of Hep C RNA, so they don't just clear infection, they actually do it better and better. And we've in fact had patients who've cleared up to 6 different hepatitis C virus infections. We call them the super clearers. And we are studying them to try to understand what their immune responses do, because they seem to be very broadly protected against various hepatitis C challenges they've experienced. So what are we seeing? So far in people who are reinfected multiple times, we see much broader, this is just a measure of how many new T cell responses develop. You can see much broader development of T cell responses than those who are chronically infected over time. That's been confirmed also by other groups, including the group in Montreal. And I think that what we're seeing, though, is that there are people who have, I haven't shown this, but there's also broadening of the neutralizing antibody response. So there is an immune response that seems to be associated with control that we're trying to further define. So I think it's going to be challenging, and there are some parallels to HIV. Hepatitis C is a very diverse virus, so I'm guessing not everyone here is familiar with reading phylogenetic trees, but basically bigger means more diverse. So this is hepatitis B worldwide, HIV worldwide, again famous for being a highly diverse virus, but if you look at the worldwide diversity of hepatitis C, it's even greater. So it's an incredibly diverse virus, so when we say make a vaccine against which hep C are we making a vaccine against? Because it's really quite diverse. So it's also unsafe to, maybe less so now with effective treatment for hep C, but it's probably not a great idea to use live attenuated or killed virus in hep C vaccines because we occasionally fail to kill or attenuate in some cases. As in HIV, there's increasing interest in vaccines that induce robust T cell responses as well as potentially neutralizing antibody responses. And so the current focus is to use a vaccine. In all cases now, the vaccines that are in development use, in HIV and hep C, use vectors, other viruses to carry in interesting hep C or HIV proteins, trying to use the other virus to stimulate a more robust immune response. And I'm not going to talk about vector immunity. Okay, so what have we seen so far? Basically, there have been a lot of vaccines tested in rodents, and the world would be a better place if everything that worked in mice works in people. But unfortunately, mice are not people in terms of testing, and so only a subset of those have then gone on to the more expensive and limited testing in macaques or chimpanzees. And really only a couple vaccines, one generating neutralizing antibody responses, and the vaccine that I'm about to tell you more about, have been tested in human beings for immunogenicity. There's only one vaccine so far that's been tested in people who are actually at risk for, high risk for hep C infection, and I'll describe that in more detail. So basically, the vaccine that's being tested in people who are injecting drugs as a high-risk population involves the use of a priming step and a boost, so 2 doses, which is not uncommon in vaccines, but obviously we want to minimize the number of doses to allow more widespread immunization. So basically, the vector is an adenovirus, so it's a relatively harmless virus in immunocompetent people that's made further attenuated, and then it carries hepatitis C inside, which I'll show, just proteins from hep C. And the boost is actually modified vaccinia Ankara, or MVA. Modified vaccinia Ankara was given to 120,000 people in Germany, for example, in a smallpox eradication campaign. So we know this vaccine vector is fairly safe, and what we've done is basically put hepatitis C virus antigens from the non-structural region of hepatitis C, and by we I mean Kairos, put hepatitis C antigens into those 2 vector systems. And the reason that was chosen is that it has several known CD8 and CD4 T cell epitopes, or things targeted, and also is a relatively conserved region of the protein of hep C. And the genotype chosen was genotype 1, subtype B for this, because it was developed in Europe where that genotype is relatively common, So in the healthy volunteers, what did this vaccine look like? Basically, it was a really highly potent inducer of T cell responses. All individuals who received it, and again, these are healthy people who are not injecting drugs or otherwise at risk for hep C, did make a response to the vaccine. The majority of subjects developed responses against more than one part of the hepatitis C used, and that's shown here. So basically, along the bottom, you see the hepatitis C vaccine containing antigens. So these were all in the vaccine, and you can see this is just a measure of T cell response. I won't go into the details unless anyone's interested, but basically more means more robust T cell response, and you can see that most people actually recognize multiple epitopes and that are targets, and basically the responses were improved between the first, shown on the left in circles, and the right vaccine, shown on the right in triangles. And for the immunologists in the group, the T cell responses induced were of the quality we like to see in vaccine responses, polyfunctional, made lots of cytokines that we like. Okay, and one of the questions we get asked is, does this work if you get infected with a different genotype of virus? Well, the data in healthy volunteers, who are again not infected, the responses were measured against different genotypes. So this is what happens. 1B was in the vaccine. There's great cross-reactivity, pretty similar levels of response against 1A. The response drops off a bit with 3 or 4, if you look. So they made responses against Hep C that might be cross-reactive. So how do we do this? Well, because the vaccine was also safe and well tolerated, it was moved into the trial called Vaccine as Prevention, which is a double-blinded randomized trial in which half the participants receive placebo, half get vaccine. And this is taking place at Hopkins, also at the University of California, San Francisco, and the University of New Mexico. And basically, the population is people who are largely young. I'm old enough to think that 45 is quite young. People injecting drugs who are at very high risk of infection. And they were negative at screening, so high risk but not already infected. Challenging population, but we did successfully enroll and have completed enrollment in this trial of the 540 people we targeted for enrollment. So the goal is really to assess the safety of the vaccine as well as induction of Hep C specific immune responses, and importantly in this trial, which is the first time we could ever do this, does it protect against Hep C infection? And the main question was chronic infection, because most of the disease, if not almost all of it, is really mediated, as we know, by chronic infection. So prevention of chronic infection. So again, there were 2 doses, the adenovirus with the non-structural and the MVA with the non-structural proteins of Hep C, given 8 weeks apart, and we assessed immune responses at multiple time points and checked them for Hep C RNA monthly. So this is an ongoing trial, so I unfortunately can't tell you the results at this point in time, but we have at least completed enrollment and we're working on the analysis, and hopefully we will be able to tell you results before the end of 2017. So in conclusion, I think a prophylactic Hep C vaccine is needed. I think there are people in this room who agree, but what is really, I think, lacking is advocacy for that position. And people have said, well, it's going to be really hard. Well, I, as a provider, treated a lot of patients with interferon and ribavirin, and there were many, many years and a lot of phone calls in the middle of the night with patients suffering in which I thought we'd never get to an 8-week course of once daily oral medication with almost no side effects. But a few $1 billion later, we have really, really excellent treatments for hepatitis C. I think it is very true that we will not make a vaccine if nobody tries. So I think we as advocates for elimination of hepatitis C critically must advocate for this portion. If you think about the infectious diseases we've controlled, they've all required vaccines to be controlled. We have really, really outstanding treatment for syphilis. Pennies, it costs nothing to treat someone with a dose of penicillin. We have not controlled syphilis. So I think realistically we need to advocate very strongly for this as part of a comprehensive strategy that includes the things for which we have advocated strongly in the rest of this meeting. And I think that protective immunity does exist in vivo, so we may want to mimic what we see in vivo should this vaccine not be as protective as we'd like. And again, I don't know because I'm blinded. It will not be easy, but hopefully we'll let you know, at least for the first trial, at least we've managed to test a vaccine in patients at risk, which is a big step forward. And so I'm hopefully going to be able to show those results this year. And with that, I just say these are my collaborators. Importantly, this study was completely funded by the US government and US taxpayers, because again, we have very little buy-in from anyone else that spending money on a Hep C vaccine is worth it. So thank you very much, and be happy to take questions. In the panel, I guess in the panel, right?
If you compare the immune responses in vaccinees with the infected but later controlling individuals, are they at the same range?
So actually, the vaccine induces really robust T-cell responses in healthy volunteers that are more robust than anything that is ever seen in people who actually acquire hepatitis C. And I think it's an important point. We'll probably be able to learn from people who repeatedly clear the infection, but the bar might be lower in someone who has a robust immune response prior to exposure. So obviously, trying to contain a threat is very different than being fully prepared when that threat arrives. So I think the bar is lower in prophylactic vaccine development, but this responses in healthy volunteers are way off the charts.
And if you look at the viral dynamics in people who clear their second infection, is the dynamics different from the first infection? Because it's not it's not a strictly protective effect what you're seeing. It's really a secondary
Right, but they
clearing the infection response.
Right, so they have shorter durations of viremia, and the peak HCV RNA is brought down quite a bit. So that suggests, again, it's not a fixed genetic trait that people who clear infection have. And in fact, we've looked for the genetic associations like IL-28B and so on, and that doesn't explain why some of these people are able to repeatedly clear Hep C. They do induce broad T-cell responses and antibody responses, and I think they actually act much more rapidly, which is why the peak HCV RNA levels are brought down and the duration's very short. So there is a change in the kinetics that suggests that there is protective immunity in those individuals. We'd like to mimic that through vaccination. Mm-hmm.
Thanks, Andrea. Great talk. Do you think there's any appetite for doing a trial where people receive the vaccine after treatment? I mean, we've done some modelling to suggest that this is, number one, they're a captive audience. Number two, that issue around reinfection and the like. And have you any sense of whether or not people who have been previously infected rather than spontaneously cleared, but instead have had treatment and their immune response and the like, and what you might think would be the impact, any different or the like?
So I'd love to do that trial. I think, the question is, do you wait and see if this vaccine has some efficacy in the lower bar, which is probably taking a naive, never exposed to Hep C immune system and shaping it in exactly the way you want, as opposed to someone who's already seen Hep C and become essentially exhausted and the immune system doesn't respond anymore. Trying to reawaken that is probably a more challenging scenario. But I'd love to see if there is any protective response. The other challenge is when you take patients who are treated, you'd have to take people who are at ongoing risk of infection and see a difference in the rate. So it's also going to be a challenging trial setting in which to test a vaccine. But I think it'd be an interesting question and potentially very valuable for people who are at even slight risk of acquiring Hep C again. And it could make it much more cost effective to treat those people because you have a way of preventing reinfection. Jordan?
Well, first of all, congratulations on enrolling that trial. That's impressive, and kudos to you.
Great teamwork.
So I have two quick questions. One is, in the healthy volunteers that you vaccinated, have you looked at the duration of those protective responses? So have you looked later than the initial response to see whether they have good memory responses? And secondly, I think you've told me this before, but I don't remember. What is your threshold for efficacy in the trial in terms of protection?
Mm-hmm. So to answer the first question, the first question was at duration. Yeah, duration of immunity. To answer the first question, in healthy volunteers, we've looked out a set period. I mean, the responses seem to be durable. What we'd like to do, and we actually just wrote a grant to do this, is to determine if the responses are durable in people who are highly at risk, and if the vaccine offers protection, if they are sufficient a year or two, 3 years later to offer protection. And so we don't know the answer to that. I'm hoping that we'll be allowed to continue to follow people highly at risk so that if we see a reduction in infection, if that's something that's carried forward in time. And the second question, is we have defined an absence of chronic infection. So everyone's followed for 20 months or 9 months after infection, whichever is longer. And the goal is to see a reduction in the persistence of the virus. So if the virus created sterilizing immunity, meaning nobody got infected, that'd be great. But that's a high bar, and we probably could do a lot of good if we just kept people from being chronically infected. So that's why the outcome of the trial was set. And it was set, we're hoping to see a 60% reduction in the persistence of the virus.